Good morning, everyone. Mayara, can you please move to the next slide? Good morning. This is Margie Giuliano. I'm the regional lead for our medication safety work at the Quality Improvement Organization. On behalf of the New England QIN-QIO and our partners at the New England Rural Health Association, I'd like to thank you all for joining us for today's session. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. The recorded presentation will be available within a few business days after the webinar on our website. The phone lines will be on mute during the presentation, but we will unmute the lines after the presentation for questions. I'll give some instructions on how to ask questions at that time. Now, although the lines will be muted, we still would like you to actively participate during the session by using the chat function. My colleague Stephanie will be monitoring the chat window and responding to your comments in real time. So don't be shy. We'd love to hear your thoughts about what our speaker is saying and how you're addressing medication safety in your own practice. Next slide, please. Use disorders have a significant cost. Next slide, please. The cost is not only to our people, but also to our economy. According to the National Survey on Drug Use and Health, 19.7 million American adults that's age 12 and older battled a substance use disorder in 2017. Astonishingly, more than 1 million were 65 or older. In 2017, about 978,000 had an alcohol use disorder. Importantly, 2/3 of this population developed the disorder before age 65. Drug abuse and addiction cost American society more than $740 billion annually in lost workplace productivity, healthcare expenses, and crime-related costs. Next slide, please. The misuse of prescription opioids and use of heroin is one of the most significant public health issues in the United States. Opioid abuse claims more lives than motor vehicle crashes and is far-reaching. The statistics listed on this slide are staggering. Providing access to effective care may prevent misuse and the consequences such as overdose. As most of us are aware, in the late 1990s, pharmaceutical companies reassured the medical community that patients would not become addicted to opioid pain relievers, and healthcare providers began to prescribe them at greater rates. Increased prescription of opioid medications led to widespread misuse of both prescription and non-prescription opioids before it became clear that these medications could indeed be highly addictive. In 2017, HHS declared a public health emergency and announced a 5-point strategy to combat the opioid crisis. Better addiction, prevention, treatment, and recovery services are paramount. We've seen that many states have implemented limitations on prescribing and increased referral services. We need better data to track trends. Most recently, we've seen that there's been an uptick in fentanyl overdoses. We have to ensure that clinicians are effectively managing pain. As we know, this can be a very fine balance. And we want to ensure access to life-saving reversal agents, and we need more research. Researchers believe that genetics may account for up to 60% of a person's risk of addiction, but note that environmental factors, including life experiences, education, and family, also impact risk. People who experience trauma, especially adverse childhood experiences, are at an elevated risk for substance use disorders, mental illness, and physical disorders. Next slide, please. Trauma-informed care is an evidence-based approach to deliver health care in a way that recognizes and response to the long-term health effects of the experience of trauma. In 2014, Treatment Improvement Protocol 57, the Substance Abuse and Mental Health Services Administration, SAMHSA, addressed trauma-related prevention, screening, assessment, intervention, and treatment issues and strategies, providing a framework for organizations that wanted to take a trauma-informed approach. So upon completion of this event, you should be able to explain the connection between adverse childhood experiences and substance use disorders, describe promising practices for implementing the trauma-informed care approach, and consider how trauma-informed care might work in your organization. Next slide, please. Today's speaker has no relevant conflict of interest to disclose. I just want to highlight that individuals wishing to receive CTE credits must participate in the full session and complete the session evaluation. Details, including the CTE code, will only be provided at the conclusion of the session. Next slide, please. So as I shared during this call, we want you to use the chat feature so that we can hear from you. So please chat in with questions and comments on the presentation, any of your initiatives and experiences, as well as what you might need some assistance with. So let's start by seeing who's on the call. Please type in your name and role, your organization, and your state. Next slide, please. And now I'll introduce today's speaker. Jennifer McCarthy is a Senior Program Coordinator for Care Transitions at Health-Centric Advisors. Ms. McCarthy brings a wealth of knowledge with integrated and trauma-informed behavioral health care and is an innovative educator and quality improvement facilitator. She's been recognized for developing cross-component relationships and served as a subject matter expert for the National Council for Behavioral Health, SAMHSA. Jennifer has a bachelor's degree in geography, master's degrees in education and counseling, and is currently working towards a doctorate of health professions education. In addition to being Lean Six Sigma certified, she is a licensed clinical professional counselor. Prior to joining Health-Centric Advisors, Ms. McCarthy worked as a practice facilitator, helping Maine physicians achieve their quality improvement goals. In 2016, she received the Behavioral Health Excellence Award from the Maine Primary Care Association, and in 2006 was a Master of Change recipient from North Shore Community College. So next slide, please. Please join me in welcoming Jennifer McCarthy.
Thanks very much, Margie. That was a great introduction, and I'm really thrilled. I was looking at the chat and seeing that we have a real wide variety of participants, so I'm so thrilled to be here, and hopefully you're going to get some good information out of this time together. Next slide. So Margie reviewed our objectives for today, so I'm going to jump right in. We can go to the next slide. So the first up is talking about the connection between adverse childhood experiences and substance use disorders. Next slide, please. And then one more. I've got some funky graphics in here. So I thought I would start off with this quote because it's really powerful. Mochtinger, who is Edward Mochtinger, he is a leader in trauma-informed care, trying to get primary care organizations on board with this type of approach, and so he coined this phrase. So trauma is the original gateway drug, opening the pathway to depression, anxiety, substance use, health problems, and early death. I mean, if I did nothing else but present you with this slide, I feel like this is really the essence of trauma-informed care and how it relates to chronic health conditions and specifically substance use disorders. Next slide. One more. Thank you. So when I've been doing this talk and when I worked with patients prior to joining Health-Centric Advisors and being a practice facilitator, I was the behavioral health consultant at an FQHC here in Maine. And when we were becoming trauma informed, we were making certain assumptions that everybody knew about what trauma was. So I was talking with a patient, and I said, "Oh, can you tell me a little bit about your trauma history?" And she said, "Well, I wasn't in any car accidents, or I didn't have any previous injuries." And that's when it dawned on me, wow, I make a lot of assumptions thinking that people understand what trauma is. So if you could take a moment to type in how you think you would define trauma, and then that's going to lead us into a little bit more of a discussion. See what people have to say. What do you think of when you hear the word trauma? Excellent. Okay. Physical abuse, neglect. Yep. Any event that's adversely like, ooh, we've got a good group here. Emotion reaction, good. Life-altering experience. Oh, I'm preaching to the choir today. This is great. Excellent. So I can see that people really are understanding that it's not necessarily an accident or traumatic injury to the brain, say, that it's something that is an event that has had a lasting effect. Wow, excellent. Oh, this is wonderful. Thank you very much for participating in this. You can move to the next slide. So SAMHSA, they're Substance Abuse Mental Health Services Administration. They're the ones that define trauma. And basically it's the 3 E's. And just a little side note, I like to affectionately call it Tik Tok. So as we move through, you're going to hear my references to different fun ways to remember what trauma-informed care is. And so this is the first one, the 3 E's. So trauma is an event or of actual extreme threat or physical or psychological harm which an individual experiences as traumatic and then causes long-lasting effects. So I always like to tell the story that if I experience something that's traumatic, my coworker may not view it as the same way. So we can't make assumptions that just because something that was upsetting to me is going to, my coworker is going to react the same way. Trauma and the experiences are very individual, and it really depends on the type of environment that someone has grown up in and any kind of predisposition, which we will talk about in a minute. But just really try to remember that it's very unique to the person experiencing the trauma. Next slide. So here we are talking about the opioid epidemic. You can't, take 2 steps without hearing about this crisis that we have on our hands. And I really liked the Campaign for Trauma-Informed Policy and Practice. They came together to really try to address the opioid epidemic. And their stance is that in order to really combat this epidemic and try to help people who have substance use disorders is to get to the root cause, which is trauma, adverse childhood experiences. So this is their position statement saying that in order for us to tackle the epidemic, we need to acknowledge that trauma is part of a person's history and that we need to take a trauma-informed approach. So if you can move on to the next slide. Thank you. So ACEs, this is, again, the second thing. So first we have the 3 E's, and now we're on to ACEs. And I know I'm talking to a group of people who really have a good sense of ACEs, but it's worth repeating. Back in 95 to 97, CDC and Kaiser Permanente did a large study where they asked 17,000 people 10 questions. And these 10 questions were based on the 10 types of trauma. And here are the results. So 1 in 4 people were exposed to 2 or more categories of ACEs. So that's what you would say. So if there's 10 questions and 10 types of categories, then there's 10 types of ACEs. So 1 in 4 people scored more than 2 types of ACEs. And then 1 in 16 had 4 or more. So that's somebody who, had maybe neglect, abuse, natural disaster, any kind of trauma that they were exposed to counted on this questionnaire. And so I really want you to take away the fact that back to that 1 in 16 exposed to 4 or more categories, that it actually can take 20 years off of somebody's life. That's pretty profound. We're dealing with people on a daily basis who maybe had 1 ACE or 2, but when you're starting to move towards somebody who has 4 categories or more, they really need help and they really need sensitivity. And so glad we're talking about this today because as we move forward, you'll see how we're going to be able to help these folks. Next slide. So this is a famous pyramid about ACEs. And so I just really want to say, too, that it's not necessarily just folks or, kids who've experienced adverse childhood experiences. You can be an adult. You can be a young adult. You can be an older adult and experience a traumatic event. So, but this is really sort of where the study came from and really the depiction of ACEs and how they affect people. So as you can see, if somebody is exposed to an adverse event, then it can disrupt the development, and then it can impair functioning. Then as you get older, you start feeling the pains and the aches of being traumatized, isolation. And what you want to do is you want to numb it, you want to hide it, you want to just stuff it down, and so then you start developing risky behaviors such as smoking or drinking or shopping or gambling, and then of course, these things can lead to chronic disease and then eventually an early death. So I hate to be depressing about it, but this is really the reality of somebody who has been experienced adverse events. Next slide. I liked this. I just found this recently. It's called the pair of ACEs. And so really what it does is it sort of hones in on the fact that not only if somebody has experienced adverse events, but if they're coming from an adverse environment, imagine how profound the effects will be. So as you can see, if somebody has been exposed to emotional abuse or substance use or domestic violence, and then they're living in an environment where there's poor housing or lack of access to care, there's lots of violence in the neighborhood, you can see that it's really going to set somebody up to be so stressed out and triggering chronic disease and other types of health risk behavior. So if this is really a powerful slide, the pair of ACEs. Next slide. One more time. So here's two studies. If the ACE pyramid, the ACE questionnaire, and the pair of ACEs wasn't enough for you to believe that there's a link, I've got some good evidence for you here and some research. So QIN et al. In 2016 did a study where they saw that adults who reported 5 or more ACEs were 3 times more likely to misuse pain medications and 5 times more likely to engage in injection drug use. Wow. I mean, that's staggering. And then the next study that was done in 2009 found that over 80% of patients seeking treatment for an opioid use disorder had experienced at least one form of childhood trauma. So this is real. The link is real. The connection's real. And I'm glad we're here talking about it because this is going to be the way that we're going to help to tackle this opioid crisis. Next slide. Okay, and one more. Thanks. So what we just did was establish that there is a connection, and so now you're thinking, all right, what do I do? Well, you could become trauma-informed. And people, I've been traveling around New England talking about becoming trauma-informed, and oftentimes when I do present it, people get overwhelmed. Oh my goodness, where do we even start? How are we going to do this? And it really doesn't look as bad as the 8 steps that I have listed there. Really what it is just trying to do a few steps and trying to engage your leadership team and your staff in understanding that trauma-informed care is a way of thinking about how we do business. Not that it's a stop and a start, but that this is the way we care for people. And it's very similar to being in a patient-centered manner. It's very similar to addressing social determinants of health. It's very similar to health equity. So this is just another way for folks to package how to treat patients. But really, I don't want you to be overwhelmed and frightened by the process of becoming trauma-informed. I do want to say that folks in the behavioral health world have been trauma-informed for quite some time. Primary care is following suit. I've been working in long-term care facilities, and I'm hoping to, get into hospitals as well, because really everywhere we go, the trauma-informed approach is really beneficial. There are trauma-informed communities, trauma-informed school systems. There's even trauma-informed states Oregon and Wisconsin are fully trauma-informed, and I believe Utah is working on it. So this is really, powerful stuff, and we're really at a good time when we could be learning what to do to become trauma-informed. So I'm, just because of the brief time that we have together, I'm not going to be able to go through each step, but it is my way of saying that I can come out and visit with you and help you and provide some technical assistance. But again, it's really not that hard. If you go to the next step, the next slide. So we're going to talk a little bit about how to do an organizational self-assessment in a minute, but really this is the crux of trauma-informed care. So if you have somebody who comes to you with any chronic condition, but we're talking about substance use disorders today, if you immediately go on into the judgment zone, or the taking a stance of what's wrong with you, why are you here, what happened, what's going on, why are you doing what you're doing, that's very hurtful, and it makes people go on the defense. So people who have experienced trauma or adverse events have had their trust broken, and there's often been a power differential, meaning that whoever was perpetrating the adverse event had more power over the person who experienced the event. And so for folks who have adverse events and substance use disorders, these folks have been marginalized, they've been stigmatized, they've burned bridges because of the behaviors that they've exhibited, and so how are they supposed to gain access to care if they already feel like they're going to be judged as soon as they open the door? So instead, we want to shift our thinking and saying, what helps? What happened to you? And doesn't that already feel better? Because I know, some days if I come in and I'm feeling tired and someone looks at me and says, well, what's wrong with you? Why do you look so tired? That doesn't feel so good. But if somebody looked at me and said, wow, you must be going through a lot. I really feel, geez, what can I do to help you? That takes me off the defensive and makes me want to be more open and engaged with the individual. So I've heard people say, for example, my mom passed away a long time ago, and then I think I was getting teary one day, and someone said to me, well, aren't you over that yet? That's so hurtful. What they could have said is, wow, what a profound loss you've had. Is there anything I can do? That must have been so hard for you, but I'm glad you're here today to get some help. So that's really the essence of trauma-informed care, is what happened to you versus what's wrong with you. Next slide. So where does it all start? You could do an organizational self-assessment, and I have included this in an attachment for our webinar today. Basically, it's a few pages, and what it is it's done by domain. And so you take your team, and you may already have a quality improvement team or a team that does some innovative planning at your organization. You would all take that assessment, and then the gaps form your implementation plan. So if you have most of the things on the list and you need to do a few things, great. Then you are further along being trauma-informed than you thought. Which leads me into my next slide. Please. Thank you. So the Missouri Department of Mental Health, they were pretty smart in how they were thinking about becoming trauma-informed, because, it can be overwhelming. As I said, you saw the 8 steps, and you're thinking, wow, where do I start? How do I even tackle this? But if you think about it from sort of a developmental stage, and most of us are in behavioral health and medicine, we get how things mature. So if you go to the next slide, we want to see where you're at. So if you're trauma aware, then your organization is aware of the fact that trauma is prevalent and that there might be some effect on the people that you serve or even your staff. If you're trauma sensitive, that means you're starting to explore the principles and you're getting ready to integrate into your policies and practices. If you're trauma responsive, you've done a lot of the work to integrate, and now you're just starting to make this a regular way of your practicing. And then if you're trauma informed, this is your standard. This is how you do business. So I wonder if you could take a minute and just kind of type in where you think your organization is. You're aware, sensitive, responsive, or informed. Good. Ooh, good. Sensitive, aware. Good. Ooh. Nice. Ooh, we've got it informed. That's exciting. This is fantastic. So we really have a really good foundation going. Nice. Sensitive. Oh, yeah. Aware. Ooh, we've got some informed. Oh, fabulous. Oh, this is wonderful. This really warms my heart. Oh, thanks again for participating. Look at that. You're completely trauma. Wow, we've got a lot of trauma informed. Oh, this is great. Wow. All right. Well, thank you. Keep typing in, and we can move to the next slide. We'll keep on going. So those of you who are trauma informed, you're aware that the core principles really form how you do your business. So let me just take a minute and say that it's really important that not only are we trying to become trauma informed to help the clients or the patients, the residents, whoever we do business with, but it's also for our staff. It's really important. We know as caregivers that we have to take care of ourselves first before we can take care of others. And so it's really important for an organization to have this environment where people feel safe, where they can trust what's going on, trust their supervisors, trust the processes and decisions that are made, that they have some sort of choice and control over what they do. Of course, we love collaboration and empowerment. So if staff feel like, if they have an interaction with a patient or a resident, a client, someone, and they don't feel like it went well, they need to feel like it's safe enough to go to their supervisor and have a conversation and say, please can we debrief? I just had an incident where it doesn't feel so good and I want to know how I can do things differently. That's really important. But oftentimes in workplaces, people don't feel comfortable to go to their supervisor. Or how about clinicians or medical providers who maybe don't feel comfortable sharing the fact that they might need to know a piece of information, but they're too afraid to admit that they don't know it. If you've set up an environment where people feel comfortable to share and say, you know what, I don't know that, but let me go ask somebody or let me go get some help with that, that's how you're going to build a healthy environment and a healthy organization. And then you take those qualities and you welcome people who have experienced adverse events, and translate that into the care. They're going to feel so safe and nurtured and not judged and want to engage in care. So these are the core principles. Next slide. And yeah, thank you. So again, continuing on these guiding principles, universal precautions. I work in a quality improvement organization. I'm learning more and more about, hospital work and nursing home work, and that you have standard precautions. So this is similar. So we have a universal precaution where we assume that everyone's experienced some type of adverse event unless otherwise notified. So if we just set up our system so that we just assume everybody's had some sort of experience, then you don't feel like you have to make all these different types of accommodations. It's just this is the way we do what we do. And then trauma-informed lens is just another word for empathy. I mean, everybody who works in this field has empathy. It's the ability to take yourself, and while you're talking with somebody who's experienced an adverse event and they're sharing a little bit about it, it's for you to be able to try to walk in their shoes for the moment, or be as close to their feelings without having experienced them yourself. So it's using that trauma-informed lens to care for the people that you work with, and your colleagues, and your supervisors, and anybody else, other stakeholders that you interact with. Next slide. All right, so now we've talked about the connection of adverse childhood experiences and substance use disorders. We've talked a little bit about what it would be like to be trauma-informed, so I want to talk to you a little bit about what it looks like. So again, I was at an FQHC who became trauma-informed back in 2015 to 2016. And so, excuse me, it took us a little bit, but what we did was we had an implementation team, and it was a multidisciplinary team, so it was people from all across our organization. We had an HR representative, we had the medical director, we had the behavioral health director, myself, care coordinator, and we had a patient. And that, to me, was the most important member of them all. So we had a patient who weighed in, and just so happened, he was nominated by our medical director, but it just so happened that he had a trauma history, so it actually ended up working out well because he could really tell us from his perspective what it would be like to access care in a trauma-informed organization. So the 4 R's. So remember back, we had ACEs, we had the 3 E's, we had what happened to you versus what's wrong with you. We had the core principles, and now we've got the 4 R's. So the first one is we realize that there's a widespread impact of trauma. And so we want to set up an environment, or we wanted to set up an environment. We started a medication-assisted treatment program. And so when we wanted the folks who walk through the door to feel comfortable from the start, we wanted them to feel like this is a safe place for them to come and get their care and not to feel judged. And so really that's about, a whole trauma-informed approach is everybody's trained from front desk all the way up through leadership, board of directors, and when we did hold trainings, our facilities manager was like one of the best participants. So we can't overlook just because somebody isn't having a direct contact with the patient that they're not going to be a great contributor to the process. So we wanted to provide a safe and nurturing environment. Next, recognizes. Oops, sorry, if you can go back, that was my fault. We recognize that there are signs and symptoms of trauma in the people that we work with and also our colleagues. So we're going to talk about that. So you want to pre-screen and screen. And when I conducted the pre-screening appointments for our medication-assisted treatment program, we used the opioid risk tool. This is because this is prior to us being trauma-informed. I used the opioid risk tool, and it had a question, have you had a history of pre-adolescent sexual abuse? And people were taken aback by it, but it gave me the opportunity for the first time to help them understand that there was a relationship between adverse childhood experiences and substance use disorders, and it was a light went off, and they felt so relieved, like for the first time someone actually was helping them understand why they did what they were doing and how can they get on a path to recovery and how can they get hope. And so it was really a beautiful thing. And I think as we became trauma-informed and rolled more of the principles into our MAT program, we really, it was just a beautiful thing to see. But that's for another story. Maybe we could do another webinar on MAT. But we want to go on to the next one, which is response. So what we did, you want to make sure that when you're being trauma-informed that you're having these practices throughout your policies and procedures and practices. And so I want to highlight one of them, which was we had a monthly meeting called the Patient Action Review Committee, where we would talk about high-risk patients or high utilizers of services, maybe people who hadn't engaged in a while. And so it was my job to make sure that as we were trying to come up with a multidisciplinary approach, that I reminded everybody, well, maybe there's a trauma history, or maybe there's something underlying that we don't know about. And so oftentimes I would end up calling the patient, scheduling an appointment, and helping to do a little bit more of a further explanation into their history so that I could help them understand this is probably why you're feeling the way you're feeling. And that made them feel so good and so supported. The last one, resist. This is a tricky one because I did re-traumatize a patient one time. I'm a seasoned counselor doing this 25 years, but because I was of my fervor in wanting to help somebody get the care that they need, I pushed them too far and didn't listen to them. And I did re-traumatize them. And when I say re-traumatize, I mean that I triggered them enough that they needed to take to their bed for 2 days. And I was so horrified that I had done that, but my heart was so in the right place. And it was well-meaning because I really just wanted this person to get the care that she needed. But instead, I re-traumatized her. So what could I have done differently? Well, I probably could have listened to her because she said no to what I asked. I wanted her to see a psychiatrist, and she said no, she wasn't ready. And did I listen? No. And I pushed a little further. So really, our hearts are in the right place, but we want to make sure that we're using motivational interviewing skills and partnering with patients. Particularly, again, with substance use disorders, because we want to make sure that we're not alienating them and singling them out or making them feel stigmatized. We want them to be able to connect with us. Next slide. So just a quick thing about pre-screening and screening. Back to that patient that we had as part of our plan or our group, is we were ready to just go and give the full screening tool, either the Adverse Childhood Experience Questionnaire or the Life Events Checklist. And he said, whoa, pump the brakes on that one. We need to go slowly with this. And so while we were watching some webinars as part of being in our Trauma-Informed Care Collaborative, we came across Dr. Shauna Grady, who, I don't know if she developed these two questions, but I credit her with them, so I'm going to give her the full credit. So she came up with, one, have you ever had an experience so upsetting that it changed you spiritually, emotionally, physically, or behaviorally? And then here's the key part. Do those problems bother you now? And then I do a 2A. Do you want to discuss them right now? So you could have somebody say yes to number one and even yes to number two, but no to 2A, meaning, okay, we're done, we don't want to talk, that's fine, I respect that. And that goes back to that motivational interviewing, and respecting and partnering with the patient. But if the person wanted to learn more about the connection between adverse experiences and substance use disorders or their chronic conditions, then if you could go to the next slide, you could administer one of the evidence-based screening tools. So on the left-hand side is the ACE. This is the original questionnaire that was given during the Kaiser Permanente research. And then there's the Life Events Checklist, which is on the right-hand side. And we actually chose the Life Events Checklist versus the ACE questionnaire. And that patient that we had as part of our group really backed us on this decision because the ACE questionnaire can be graphic. And I'm even looking at question 3, if you can see it on your screen. It's very graphic, and we thought that would be too much to, here we are trying to help people engage, and then we're going to go and ask them, question 3. So we skipped that one and went right to the Life Events Checklist. We liked this one because it has 17 types of trauma. And not only did it happen to you, but did you witness it? Did you learn about it? So, adverse experiences aren't necessarily that it has to happen directly to you. It could be that you saw something, that you learned about something on the news. I had several patients who were very upset by the 2016 election. And I'm not getting political. I'm just stating the fact that these few people that I worked with were very traumatized. And I had to work with them to de-escalate and come up with a safety plan because they were so stressed out by the results. So I really like the Life Events Checklist because it really gets to the different types of trauma that somebody can experience. Next slide. So just quickly, a little bit about the workflow, because, quality improvement organization, I'm always going to talk about how to do things in an efficient manner. This is how we did it. We had the medical assistant or the care manager ask the pre-screening questions, and they did this as part of the physical exam, the annual wellness, and new patient visits. That's what we decided to do. We thought it would be the most normalizing way to ask these questions. And then if they got a positive response, they would tell the medical provider, and the medical provider would bring me in as the behavioral health professional. I would have a chat with the patient, and then we'd decide whether they wanted to do the full screening tool, or if they just were like, no, I'm okay, I just wanted to learn a little bit about it, what's going on, or, you know what, I'm ready for some treatment. So that's just something else that I could come out and help you with is workflow. Next slide. So now that we've got people engaged and they feel comfortable and we've got them screened, and now you're thinking to yourself, well, what do I do with them now? Great question. If you're fortunate enough to have on-site mental health like we did, great, you can make a referral. But if you don't, I can see there's a lot of behavioral health organizations on with us, and I know that there are accessible behavioral health organizations across Maine, New Hampshire, Rhode Island, Massachusetts. So these are some of the types of treatment that they're practicing. I'll just go through a little bit quickly. sanctuary model isn't a treatment, but it's more of an in-depth way of doing trauma-informed care. And Dr. Sandra Bloom she's the one that coined that model. But the rest of them are treatments. And so Seeking Safety, Dr. Najavitz, she's from Boston University. That's about trying to help patients feel safe in everything that they do because, again, that trust has been broken, and so they need to feel safe and secure in the relationships that they're developing. We know about cognitive behavior therapy, looking at your feelings, behaviors, and actions, and so it just has a trauma-focused slant, again, trying to help someone get adjusted to the way they process their trauma and try to help reduce the negative behaviors that come from traumatic experiences. Trauma recovery and empowerment model. This was developed by Fallett and Shapiro. They're some of the front runners in the trauma-informed care and ACEs childhood adverse events research from way back. And eye movement, desensitization reprocessing, EMDR, fantastic type of trauma reprocessing. Boy, Francine Shapiro, if anybody's worked with this, or I've actually had a session, and it really helps. And it's really, you can either do it by tapping your hand or using a light machine, and it really does reprocess your memory for experiencing a traumatic event. One of my favorites is Somatic Experiencing by Peter Levine. Folks who have experienced adverse events are often disconnected or disassociate anything that they can do to survive. So somatic experiencing is literally helping people get connected back into their bodies and their environments. So you sit in a chair and you help a patient look around the room and try to point out 3 things, maybe tell me the time, what's on that bookshelf, and then your feet are planted firmly on the ground, and then you put your hand on your stomach and you're like, all right, I'm grounded, I'm centered, here I am. So that's just a little snippet of some treatment types. There's also prolonged exposure. I mean, I could do a whole show on that, but that's at least a start for you. And all the references are, all the links are in my references for you. If you can move on. SAMHSA, of course, does a wonderful job with their tips. I'm sure you've seen them. You can go to their website and to their store and download these packets. They're great. Tip 57, of course, is all about trauma-informed care. And tip 63 I like because it's about opioid use disorder and has trauma-informed care approaches throughout the booklet. We're getting to the end here. If you could go to the next slide. There's my TikTok. That's what I call it. We call it the TikTok. So a fun way, when I went through college, I had mnemonic devices and catchy ways to remember things. So I thought this is a fun way to kind of get to the end, which is, what is an ACE? Or you can walk up to somebody and say, hey, how many ACEs do you have? Or did you have any ACEs? Wow, you've been through so much. You can say the 3 E's, what happened to you versus what is wrong with you, the universal precautions and the trauma-informed lens, the 4 R's, and the core principles. Woo! Sounds like a lot, but it isn't. It's just good care. Next slide. And one more, because I got my fun graphics here. This is what a trauma-informed care organization looks like. And we know these are organizations right now. I really want to reiterate that I don't think you have to scrap everything you've done and start from scratch. No. We are always trying to care for the caregivers and increase and improve the quality of our services. I think this just helps us to take a step back, have a little bit more of a compassionate way of doing things, and making sure that we're checking in with our staff and our medical providers and clinicians because they can get burnt out from dealing with people who have had adverse experiences. Next slide is my last one and most dramatic. Yeah, thanks. If you can kind of go through. Trauma-informed care is not a destination. It is a process and a way of doing business. So it's not a stop and a start. It's just this is the way you run your business. We can use a trauma-informed lens to make sure that we have empathy and making our environment safe and nurturing for people, that we partner with the folks that we work with, that you can take the changes one step at a time. And then Margie McLaughlin, who's one of our wonderful consultants here, she developed the nifty slogan, "Here with your heart." On the left side is shift your perspective. That's the state of Wisconsin, their nifty slogan. Maybe your organization can come up with something clever to say. The reason why I like hear with your heart or shift your perspective is we're all about, when we're working with people with substance use disorders and people with chronic conditions, I really want to reiterate that. You know, I'm talking about substance use disorders today, but this is good care for everyone. That if you're at the nurse's station and you hear somebody say, oh, well, she's got a dirty urine, or he's a drug seeker, instead of saying to that person, wait a minute, you shouldn't be saying that, or don't say that, you could say, are you hearing with your heart? Do you hear what you're saying? You know, is this how we want to treat our patients? Is this how we want to treat each other? So it's just a great way to latch on so that people can, kind of do some self-correcting without feeling their own trauma or stigma from saying something that maybe wasn't correct. And finally, I came across this quote, hurt people hurt people. You have to know that people who've experienced adverse events are hurt, and they turn around and hurt people. And so we're trying to help them understand that if they can see the link between adverse experiences and why they do what they do, then they're not going to hurt people anymore, and then they're going to have their hearts open to get some help, and then we're going to be able to engage with them more because they're not going to have that wall up. So there, hurt people hurt people. That's really powerful. And I just see in the chat, compassion first. Fantastic. That's excellent. So we've got another motto to add, compassion first. All right, next slide. I think I'm here if you have any questions or you want to talk more about this topic. I'm very passionate about it. Just about everything I'm doing right now has to do with trauma-informed care. It's my project in school. So contact me and we can talk. The next slide is, I think we're going to start a little bit, so I've got my references. And if you scroll through, yep, and then we get to the part where we see if we want to open it up and see if folks have questions.
Thanks so much, Jen, for that amazing presentation. So let's jump in and join Jen with questions and comments. Nayara, can you remind people how to unmute their line?
Sure. If you'd like to ask a question over the phone, you can just unmute yourself by dialing #6.
Great, thanks. Stephanie, do we have any questions in chat at this time?
We do not, Margie.
Okay, so I'm going to take the prerogative to ask a question, if you don't mind. Jennifer, obviously I would assume that becoming more trauma-informed comes with a cost. So how do you justify the time, the cost, and the effort to become a trauma-informed organization? And what are those additional costs?
Well, you asked a great question, and I was doing some preparation for that, and I was having a conversation with some colleagues today about that. So believe it or not, there's not a lot of data to show the cost-benefit analysis of being trauma-informed. So I looked. But what I can say is it's similar in being sensitive to social determinants of health, health equity, being patient-centered. It may be a while before we are able to see the lasting effects of being trauma-informed, but we know it's good care, and we know that I think with 60% of adults who present themselves to primary care have had an adverse experience. So if that's more than half of the people that walk through the door. If we're trying to help them understand the connection between their experiences and their chronic conditions, we can only imagine that it's going to help, of course, reduce readmissions and high utilization, and it's going to increase engagement, which would eventually increase self-management, which would reduce the burden on the healthcare system. So I think that's to be continued. I think it's probably still early on to see anything quantifiable, but I'm hopeful and I know that it's good care.
Great, thank you. Steph, is there anything in chat?
Can I jump in? This is Lisa. I missed the first part of the presentation, so I apologize if what I'm going to say is
redundant to what's already been said. I don't have professional experience with regard to this, but I do have personal experience with a very close family member in my immediate family. And so a couple of things that I've seen, this person had to go through substance use inpatient treatment 4 times before it kind of took. And in talking to many of the others who were there, because we had a lot of conversations, what I did become aware of was that virtually all of them had suffered a very significant personal loss, either a split family where it was not acrimonious or where it was acrimonious, a suicide, unexpected or untimely death, things of that nature. And I think that the approach of recognizing that something really significant has happened in these people's lives that is hard for them to talk about, which is probably some of why they turned it inside into themselves, is so important for the treatment to be effective, which then leads to the fact that there's almost always a comorbidity that I've seen, which then substantiates that these 28-day cycles of bring them in, give them super support, but then just push them back out doesn't work, And the last thing is, of course, that with substance use disorders, it's not until the person themselves finally realizes that they need support, that they need this kind of treatment, and that what they're doing is not the way they want to live. Until that happens, it's not going to click with them completely. I was talking to people, and when I said, we went through it 4 times, and they said, well, that's okay. We went through it 12 before it took. And almost everybody in the program has been through it multiple times. So, we have to recognize that it's truly a journey, and we have to, I think this approach is 100% on target, but I think that it needs to be modified some to understand the depth of the issues.
Wow, thank you very much, Lisa. That was great.
Hi, this is Stephanie. So we do have a couple of questions in chat, and one from Carol. Have healthcare providers been compared with the general population on ACE scores? She's wondering how many caregivers have trauma histories.
Ooh, that's a good one. Let me just scroll up and see that one again. Healthcare providers being compared with general population. So are you asking, Carol, if healthcare providers have checked their own ACEs? Does that sound like it? And you wonder how many? Yeah, caregivers have trauma. Oh, I'm sure tons. I don't have numbers, but I can tell you that just from personal experience, we had a medical provider at our organization who was triggered. She had her own trauma history and was triggered by a patient, and it wasn't handled well at all, either from her or from leadership, even though we were trauma informed. So you're raising such an important point that we're humans and we interact with people all day long who have their own experiences, and so we need to somehow keep our stuff in check. So, again, don't have numbers, but that's an excellent question, and I think that's why when we talk about the trauma-informed approach from an organizational standpoint, we're looking at each other, so all the staff, as well as whoever we're serving. So thank you for bringing that up.
Great. And we have a couple other comments, too, in chat from Peter. He mentioned that they find that their medication-assisted treatment program, they have to demand compliance while being compassionate and helping without enabling, which can be tough. And from Carol, trauma-informed systems have a possible transgenerational benefit. And then we do have a question from Susan. Do you recommend assigning a diagnosis on the patient chart when you recognize trauma?
Great question, Susan. I would think so, and that would be, so in my role as the behavioral health consultant, I didn't formally diagnose. I left that to the medical provider, But yeah, I think it would be helpful because, and oftentimes they would get a diagnosis of PTSD, just so that in case they do seek treatment, that it would be covered by insurance. Sorry to be so, business-like, but that's the truth. And also so that patients can start to own and acknowledge what they've experienced so that they can start to make sense of what's happened and how they can move forward. So yes, excellent question. I would definitely recommend a diagnosis.
Great, thank you.
Nayara, anybody on the phone with questions?
I had a question. I typed it in. Can you hear me?
Yes.
Oh, thanks. So I just typed it, but it's not very well typed. My question is about how the principles of trauma-informed care can be relevant either to concepts like harm reduction among various populations, whether it's injection drug users or survivors of, say, commercial sex work, or at the other extreme, is there any attempt to incorporate trauma-informed care principles in the way that certain very traumatizing agencies or departments of government can work? And I had in mind either departments of corrections or DCYF, any attempt to really modify how they do their work. So
absolutely. Yes, no, it's great. So let me do the second part first, which is yes, there are, like social justice movements and organizations are trying to become trauma informed, and so police have gone through training, first responders, criminal, Department of Corrections. Yes, I mean if anything, what you can do after this is just type in trauma informed care, and you're going to see dozens of resources and references. It's really sort of the buzz. And you'll see some of the work that the criminal justice system has done to help become more trauma-informed. And then regarding harm reduction, amen. That's what we practice, and it was quite a shift for all of us, again, because we were in that mindset that people were abusing the system, abusing themselves, and we needed to make sure that everybody was abstinent. And so we, alongside becoming trauma-informed, embrace the harm reduction philosophy. I think they go together nicely because, and SAMHSA has a definition of recovery. I don't know it off the top of my head, but it's 4 parts. But really what it's based on is hope and health, and it's based on the fact that patients get to decide what their recovery journey looks like, that I'm not going to sit there and tell them they need to be abstinent or they need to do this or they need to do that. I'm not partnering with them. I'm not appreciating their history, and I'm telling them what to do. So harm reduction goes so naturally, nicely with trauma-informed approach. So thank you very much for raising that. Does that help?
Yeah, it does help. Can I ask, I guess, one follow-up question to that, which is, has there been an attempt to speak to various 12-step organizations about whether they may be re-traumatizing people who come into their community who are, for example, on medication-assisted recovery, and they are told often, not always, but often told, well, you're not in recovery because you're on methadone. To me, that seems like absolutely re-traumatizing.
And I'm sure it is. And I don't know if I feel comfortable answering that because I am pretty passionate about trauma-informed care and harm reduction. So I think it's better for me to just say that I'm passionate about harm reduction versus going down that road, because I really do believe that a person who's in recovery should be able to go anywhere they want to seek support. So I think I'll just be politically correct and leave it like that. You can read between the lines.
Thank you so much for this great discussion. Just so you know, if you have a question in chat, we will definitely be following up with you. I hate to end the great discussion, but we are almost at the top of the hour, and I want to be respectful of everybody's time. Can I have the next slide, please, Nayara? So for those of you who are looking for ACPE credit, the ACPE code is Trauma Informed. And our next slide, please. So if anybody's looking to make any connections with the QIO and you want to learn more in your state, this gives you the email addresses of everybody in the different states that you can reach out to. And I think we've got Jen's email address as well in our chat. So I will now turn over to Nayara for a final wrap, and thank you, everyone.
Thank you.
Great. Thank you for joining us today. This is just a reminder that we are on social media, so you can connect with us through our Facebook page, LinkedIn account, and we also have many videos on YouTube. Thank you all for participating today. We appreciate your attendance and great discussion, and we'll be following up with an email after with the resources, and please fill out the evaluation. Thank you.
Thank you very much.